Welcome to the second part of our discussion in anatomy and physiology. Now let's proceed to ventilation or breathing. It's the process of moving air into and out of the lungs. There are two phases of ventilation. First, the inspiration or inhalation is the movement of air into the lungs. Second, the expiration or exhalation is the movement of air out of the lungs. So ventilation is regulated by changes in thoracic volume, which produce changes in air pressure within the lungs. So from that image, you can see the effects of the muscles of respiration on thoracic volume. So the muscles associated with the ribs are responsible for ventilation. Inhaling requires a set of muscles called the muscles of inspiration. The muscles of inspiration include the diaphragm and the muscles that elevate the ribs and sternum, such as the external intercostals. The diaphragm is a large dome of skeletal muscle that separates the thoracic cavity from the abdominal cavity. Forceful exhalation requires a set of muscles called the muscles of expiration. The muscles of exhalation include the internal intercostals and depress the ribs and sternum. At the end of a normal, quiet expiration, the respiratory muscles are relaxed. As seen from that image, during quiet inspiration, muscles of inspiration contract to increase the volume of the thoracic cavity. Contraction of the diaphragm causes the top of the diaphragm to move inferiorly. Contraction of the external intercostals also elevates the ribs and sternum to increase thoracic cavity volume. The large change in the thoracic cavity volume is due to contraction of the diaphragm. So expiration occurs when the thoracic cavity volume decreases during quiet expiration. The diaphragm and external intercostals relax. The elastic properties of the thorax and lungs cause them to recoil into a relaxed state. There are several differences between normal quiet breathing and labored breathing. During labored breathing, there is a much greater increase in thoracic cavity volume. All the inspiratory muscles are active and they contract more forcefully than during quiet breathing. Also, during labored breathing, the internal intercostals and the abdominal muscles contract forcefully. This decreases thoracic cavity volume more quickly and to a greater degree than during quiet breathing. Let's proceed to the pressure changes and airflow. So there are two physical principles govern the flow of air into and out of the lungs. First, changes in volume results in changes in pressure. Second, air flows from an area of higher pressure to an area of lower pressure. So from this image, you can see that the first one, at the end of expiration, alveolar pressure is equal to atmospheric pressure and there is no air movement. While the second one, the second image, during inspiration, increased thoracic volume results in increased alveolar volume and decreased alveolar pressure. Atmospheric pressure is greater than alveolar pressure, and air moves into the lungs. The third one, at the end of inspiration, alveolar pressure is equal to atmospheric pressure, and there is no air movement. While on the last image or picture, during expiration, decreased thoracic volume results in decreased alveolar volume and increased alveolar pressure. So alveolar pressure is greater than atmospheric pressure and air moves out of the lungs. For the lung recoil, during quiet expiration, thoracic volume and lung volume decrease because of lung recoil, the tendency for an expanded lung to decrease in size. Lung recoil is due to the elastic properties of its tissues and because the alveolar fluid has surface tension. So surface tension exists because the oppositely charged ends of water molecules are attracted to each other. As the water molecules pull together, they also pull on the alveolar walls, causing the alveoli to recoil and become smaller. So two factors to keep the lungs from collapsing. First, the surfactant, and the second one is pressure in the pleural cavity. So what is surfactant? So surfactant is a mixture of lipoprotein molecules produced by secretory cells of the alveolar epithelium. The surfactant molecules form a single layer on the surface of the thin fluid layer lining the alveoli, reducing surface tension. Without surfactant, the surface tension causing the alveoli to recoil can be 10 times greater than when surfactant is present. Thus, surfactant greatly reduces the tendency of the lungs to collapse. Now let's proceed on the factors that influence pulmonary ventilation. We have lung elasticity, lung compliance, and respiratory passageway resistance. First, for the lung elasticity, lungs need to recoil between ventilations. It decreases by emphysema. So what is emphysema? Emphysema is a long-term progressive disease of the lungs that primarily causes shortness of breath due to overinflation of the alveoli or the air sacs in the lungs. Now next, for the lung compliance, expansion of the thoracic cavity and affected if rib cage is damaged. And lastly, the respiratory passageway resistance. It occurs during an asthma attack, infection, or tumor. So now let's proceed to pulmonary or respiratory volumes. So first, the spirometry is the process of measuring volumes of air that move into and out of the respiratory system. And the spirometer is the device that measures these respiratory volumes. So measurements of the respiratory volumes can provide information about the health of the lungs. So for the tidal volume or TV is the volume of air inspired or expired with each breath, while the inspiratory reserve volume is the amount of air that can be inspired forcefully beyond the resting tidal volume. While next, expiratory reserve volume or ERV is the volume of air that can be expired forcefully after a normal expiration. Then the residual volume or RV is the volume of air remaining in lungs after a maximal expiration. Can't be measured with spirometer. So the tidal volume increases during physical activity. The increase in the tidal volume reduces the inspiration and expiratory reserve volumes, but total lung capacity stays relatively constant. So for your vital capacity or VC, the maximum amount of air a person can expire after a maximum inspiration. So you just add the IRV plus ERV plus the TV. While for your TLC or your total lung capacity, you need to add the vital capacity and the residual volume. So again, this is an image of respiratory volumes and respiratory capacities. So the tidal volume shown here is during resting conditions. Respiratory volumes are measurements of the volume of air moved into and out of the lungs during breathing. So respiratory capacities are the sum of two or more respiratory volumes. This is an example of a spirometer machine. So factors that influence the pulmonary volumes includes the gender, the age, the height, and the weight of your client. So now for the diffusion of gases in lungs, cells in the body use O2 and produce CO2. So blood returning from tissues and entering lungs has a decreased PO2 and increased PCO2. So O2 diffuses from alveoli into the pulmonary capillaries. Then CO2 diffuses from capillaries into the alveoli. So this figure shows the gas exchange. Differences in partial pressure are responsible for the exchange of O2 and CO2 that occurs between the alveoli and the pulmonary capillaries and between the tissues and the tissue capillaries. So first, oxygen diffuses into the arterial ends of pulmonary capillaries, and CO2 diffuses into the alveoli because of differences in partial pressure. As a result of diffusion at the venous ends of the pulmonary capillaries, the PO2 in the blood is equal to PO2 in the alveoli, and the PCO2 in the blood is equal to the PCO2 in the alveoli. The next, the PO2 of the blood in the pulmonary veins is less than in the pulmonary capillaries because of mixing with deoxygenated blood from veins draining the bronchi and the bronchioles. Then oxygen diffuses out of the arterial ends of tissue capillaries, and CO2 diffuses out of the tissue because of the differences in the partial pressure. And lastly, as a result of diffusion and at the venous ends of tissue capillaries, the PO2 in the blood is equal to the PO2 in the tissue, and the PCO2 in the blood is equal to the PCO2 in the tissue. So it goes back to the first step all over again. So this is the gas exchange in the tissues. So in the tissues, carbon dioxide or the CO2 diffuses into the plasma and into the RBC or red blood cells. Some of the carbon dioxide remains in the plasma. So in red blood cells, carbon dioxide reacts with water to form carbonic acid, which is the H2CO3 in a reaction catalyzed by the enzyme carbonic anhydrase or the Ca. So carbonic acid dissociates to form bicarbonate ions or the HCO3 and hydrogen ions or the H positive. In the chloride shift, an antiporter allows HCO3 to diffuse out of the red blood cells and chloride ions or the Ci to diffuse into them, which maintains their electrical neutrality. So oxygen is released from hemoglobin, then oxygen diffuses out of RBCs and plasma into the tissue. So hydrogen ions combine with hemoglobin, which promotes the release of oxygen from hemoglobin. So carbon dioxide combines with hemoglobin, then hemoglobin that has released oxygen readily combines with carbon dioxide. So what is what we call the Haldane effect. So for the gas exchange in the lungs, so the carbon dioxide diffuses from the RBC and plasma into the alveoli. Then carbonic anhydrase catalyzes the formation of CO2 and H2O or water from H2CO3. So bicarbonate ions and H combine to replace H2CO3 or what we call the carbonic acid. So in the chloride shift, an antiporter allows HCO3 to diffuse into the red blood cells and chloride ions to diffuse out of them, which maintains their electrical neutrality. Oxygen diffuses into the plasma and into the red blood cells. Some of the oxygen remains in the plasma, then oxygen binds to the hemoglobin. So hydrogen ions are released from the hemoglobin, which promotes the uptake of oxygen by hemoglobin. So carbon dioxide is released from hemoglobin, then hemoglobin that is bound to oxygen readily releases carbon dioxide, which is what we call again the Haldane effect.
The respiratory system regulates oxygen and carbon dioxide levels within the blood. Respiration includes ventilation, gas exchange between the air, blood, and tissues within the body, and the use of oxygen for metabolism. Inhalation allows oxygen to enter the body, pulling air into the nose and mouth, lungs, and into the air sacs, called alveoli, where gas exchange takes place. Alveoli move freely when air is inhaled and exhaled. Capillaries are small blood vessels that line the walls of the alveoli. During gas exchange, oxygen enters and carbon dioxide exits the bloodstream via the alveolo-capillary membrane. Once oxygen molecules move from the alveoli into the capillaries, they dissolve into the plasma and enter the red blood cell or erythrocyte. Erythrocytes contain millions of soluble proteins called hemoglobin. Hemoglobin contains 4 subunits, each capable of binding one molecule of oxygen. Once one molecule of oxygen binds to one of the subunits, the other sites bind oxygen more readily. Dissolved and bound oxygen flows through the arterial bloodstream to capillaries within tissues. Upon arrival, carbon dioxide loading of the erythrocyte promotes oxygen unloading. Oxygen metabolism within cells produces carbon dioxide gas as a metabolic waste. Carbon dioxide exits the cells and tissues and is converted into bicarbonate within the erythrocytes. Converting carbon dioxide to bicarbonate releases hydrogen ions that decrease oxygen affinity for hemoglobin, freeing the oxygen to be delivered to tissue cells. After delivering oxygen to the tissues, the carbon dioxide-rich blood returns to the lungs through the venous circulation and then to the pulmonary artery. Inside each erythrocyte, the bicarbonate conversion is reversed, recreating carbon dioxide, which diffuses across the erythrocyte into the alveoli and lungs and is excreted out of the body.
So I guess that is very toxic to analyze everything, but I hope you need to read further and reread again just to ensure that you will be able to understand or comprehend the process of the gas exchange. Now let's proceed to the rhythmic ventilation. So normal respiratory rate is 12 to 20 respiration per minute or RPM. So in children, the rates are higher and may vary from 20 to 40 per minute. So the rhythm is controlled by neurons in the medulla oblongata. So rate is determined by the number of times respiratory muscles are being stimulated. So from this one, you can see that higher centers of the brain, the speech, emotions, voluntary control of breathing, and actions potentials in motor pathways. Then the medulla or the chemosensitive area decreases the pH and increases the carbon dioxide of the chemoreceptors. The carotid and the aortic body chemoreceptors decreases also the pH, increases the carbon dioxide, but decreases the oxygen. So Herring-Brewer's reflex is the stretch receptors in the lungs, then proprioceptors in muscles and joints, then receptors for touch, membrane, and pain stimuli, and lastly, input to respiratory centers in the medulla oblongata and pons modifies respiration. So these are the several regulatory mechanisms affect the rate and depth of breathing. A plus sign indicates that the mechanism increases breathing, and a minus sign indicates that it results in a decrease in breathing. So the nervous control of breathing. Higher brain centers allow voluntary breathing. Emotions and speech affects the breathing, while the Herring-Brewer reflex inhibits respiratory centers when lungs are stretched during inspiration. So there's an illustration of the regulation of the blood pH. So for the number 1, Blood pH is in its normal range. Then number 2, the blood pH increases outside its normal range, which disturbs homeostasis. And number 3, the control centers for blood pH, the medullary chemoreceptors detect an increase in blood pH, so blood becomes more basic and respond to the increased pH by signaling and decreased breathing rate. While for the number 4, the effectors, the diaphragm and other respiratory muscles respond by slowing their contraction rate, which lowers the rate of breathing. Then in number 5, as a result, more carbon dioxide is retained, which causes pH to drop, so the blood becomes more acidic. And number 6, blood pH returns to its normal range and homeostasis is maintained. Observe the responses to a decrease in blood pH by following the red arrows. So for the chemical control of breathing, so the chemoreceptors in medulla oblongata respond to changes in the blood pH. Then the blood pH are produced by changes in the blood CO2 levels. An increase in CO2 causes decreased pH, resulting in increased breathing. So low blood levels of oxygen stimulates chemoreceptors in carotid and aortic bodies, increase the breathing. So if so happen, you will receive a blood result or blood chem, so you will be able to distinguish a significant result based on the readings. So let's define first. So internal respiration, exchange of gases between the cells and the blood. Then external respiration occurs in the lungs, exchange of gases between blood and the alveoli. And the third one is the apnea. So there is a temporary cessation of breathing. While for the fourth one, the dyspnea is the difficulty or labored breathing. So that's just a common terminologies. So the fifth is the hyperventilation. So breathe very fast, exhaling more than inhaling, decreasing the carbon dioxide. And while on the sixth, the hypoventilation is also known as the respiratory depression. So there's an increase of carbon dioxide causing acidosis. And we have what we call the COPD. So what does it mean? COPD stands for, guess. Is there any guess coming from the group? So COPD is a chronic obstructive pulmonary disease. And also for the effect of asthma on ease of breathing and air passages, we will not go into details because later on, and as you go on a higher level, we will discuss these things clearly to you guys. So there's a strenuous exercise is one of the many factors that can bring on an asthma attack. So that's the picture. Then the asthmatic bronchiole and the normal bronchiole. So you can compare the two. The one is very constricted and the mucus filled it is. While the normal one, note how clear it is.
Asthma is a chronic inflammatory disease that obstructs airflow in and out of the bronchial tubes. Normally, as the diaphragm contracts and relaxes, air moves freely in and out of the trachea and bronchi to the bronchioles and then to the alveoli, where gas exchange takes place. During this process, carbon dioxide will diffuse out of the bloodstream into the alveolus, while oxygen will diffuse from the alveolus into the bloodstream. Smooth muscle in the bronchial walls is controlled by the autonomic nervous system. Sympathetic stimulation relaxes smooth muscle and produces bronchodilation when the air is warm, moist, and free of irritants. Parasympathetic stimulation contracts smooth muscle and produces bronchoconstriction when the air is cold, dry, or contains irritants. People with asthma have chronically inflamed and swollen airways that are hyperreactive to irritants that can trigger an asthma attack. Asthma triggers include outdoor irritants and allergens such as pollen, smoke, pollution, and cold weather. Indoor irritants and allergens such as mold, pet dander, dust mites, and cockroach droppings. Food allergens such as fish, shellfish, eggs, peanuts, and soy. Physiological conditions such as respiratory infections, stress and strong emotions, and exercise. During an asthma attack, these triggers can induce mast cells and leukocytes to release chemical substances such as histamine, kinins, prostaglandins, and leukotrienes. These substances are chemical mediators of inflammation that can precipitate a bronchospasm. Suddenly, the bronchial smooth muscle tightens, and the bronchial wall becomes more swollen. Goblet cells in the mucosa produce thicker mucus, further obstructing the airway. This combination of factors slows normal gas exchange. The symptoms of a bronchospasm include coughing, wheezing, shortness of breath, and chest tightness. Medicines that treat asthma affect the inflammation of the airway wall, the constriction of the bronchial muscles, or mucus secretion. The most important asthma medications are long-acting anti-inflammatory drugs such as corticosteroids, leukotriene inhibitors, and cromolyn sodium. These drugs keep asthma under control by preventing or reducing inflammation of the bronchial wall. This makes the airways less sensitive to bronchospasm triggers. Regular use of maintenance medications makes it less likely that an asthma flare-up will take place. Bronchodilators are either quick relief rescue medications, such as short-acting beta agonists, or long-acting maintenance medications, such as theophylline and anticholinergics. These drugs cause the bronchial smooth muscle to relax quickly or gradually over a longer period of time. Regular use of long-acting maintenance medication is critical in keeping your airways open and less inflamed. This reduces the likelihood of asthma flare-ups. When flare-ups do happen, it is important for patients to work with their licensed healthcare professional to develop an action plan for the correct use of short-acting rescue medication. Rescue medication opens airways quickly, providing symptom relief within minutes.
That ends our topic for this week. I hope you learn to appreciate the importance of respiratory system. So take more time to study and read more and more. So thank you for listening.